This is a short video Peopletoo have created to demonstrate how a virtual ward approach can be used to manage patient demand locally and enhance COVID recovery processes. According to new research from the Red Cross, slightly less than 1% of the population of England attend A&E at least 5 times a year. As a group, these individuals account for approximately 16% of all A&E attendances and 26% of all hospital admissions in England. A large proportion of these frequent attenders have one or more long-term, life-limiting condition. The research shows that mortality rates amongst individuals within this cohort, aged between 30 and 49, are approximately 7.5 times higher than amongst individuals of the same age in England in general. At present, recovery processes in the NHS are being hampered by a lack of capacity in acute settings, driven in part by high and rising demand for urgent and emergency care. Peopletoo have been working with a number of localities, or places, to support them in responding positively to the challenges, across health and care, posed by both the ongoing COVID pandemic and recovery efforts. Peopletoo have developed, with a locality in the north of England, a COVID recovery virtual ward service, which aims to reduce the demand for non-elective care amongst the highest frequency users of these services. The design of the service builds on the original, Croydon virtual ward model, developed in 2005 and the learnings from variations on this model, used in Devon in 2009, Wandsworth also in 2009, and Harrow in 2018. Whilst the outcomes delivered by the model variants differ, there is strong evidence that virtual wards provide a safe, cost-effective alternative to an acute admission, through a package of primarily community-based resources. The COVID recovery virtual ward model Peopletoo designed has a number of differences from the service introduced in primary care in Croydon in 2005, however it retains the core features of 1. A predictive model to identify individual patients at high risk of an A&E admission. 2. A multidisciplinary approach to enabling case management at home, using a structure, processes, and systems akin to a hospital ward. The key components of the model can be described as follows. Step 1. Primary and secondary care data is used to identify suitable individual patients who correspond to high-usage patient segments. Most virtual ward variants focus on individuals aged 65+ with one or more long-term condition. However, current system pressures highlight the need to broaden eligibility to working-age adults with complex needs. Step 2. Individuals who correspond to a high-usage patient segment but do not yet have an urgent need for the virtual ward service could be provided with care coordination services provided by non-clinical care navigators. Care navigators will be able to expedite the admission of these patients into the virtual ward if needed. Step 3. Individuals are judged to have an urgent need for virtual ward services, either following Step 1 or Step 2, will be referred to care planning to enable the creation of an anticipatory care plan. Step 4. Individuals from Step 3 are judged to have complex needs, which can be managed effectively outside the virtual ward, will be referred to a team of enhanced nurse practitioners working with social workers to provide non-urgent, home-based support when needed. Step 5. Individuals from Step 3, who the anticipatory care planner judges are potentially in crisis, will be referred to a care coordination service run by GPs with a special interest aligned to the needs of the patient's population segment, for example, diabetology or gerontology. Step 6. From Step 5, the GP with a special interest will triage the patient, referring them to the virtual ward with remote monitoring if this is the best solution. Whilst on the virtual ward, patients' cases will be discussed with a multidisciplinary team comprising, for example, social workers, occupational therapists, community pharmacists, gerontologists, psychiatrists, and other specialist healthcare staff, on a weekly basis, with care navigators responsible for coordinating the delivery of their care. Step 7. Virtual ward patients requiring a step-up bed following crisis can be referred into bed-based services. Similarly, patients discharged from hospital into the virtual ward may need step-down provision. Step 8. A rapid response service will be available to support patients in managing crises in their own home. Where required, the service can escalate to an ambulance call-out, or refer into the virtual ward's bed-based or other bed-based services, acute or community, as needed. Evaluation of a similar virtual ward model demonstrated that admission to the virtual ward lowered demand for urgent and emergency care services amongst participants in the 6 months following discharge, translating to: firstly, a 40% reduction in GP usage. Secondly, a 86% reduction in NHS 111 calls. Thirdly, a 50% reduction in A&E attendances. Fourthly, a 79% reduction in NEL admissions. Delivering similar outcomes across English systems and localities, or places, would result in substantial savings in relation to demand management and large increases in capacity to support COVID recovery processes. Angela's story demonstrates how the virtual ward service Peopletoo have developed could transform patient outcomes. In this particular example, the virtual ward would deliver estimated savings between £1,500 and £19,500 per incident, depending on the point of intervention. Angela is 84 years old. She is on cardiac medication. She has a fall at home and her husband calls an ambulance. She is reluctant to go to the emergency department but is persuaded by the paramedics just in case. She is seen by the ED doctor and given an X-ray and some blood and urine tests. The X-ray shows there is no fracture, but the urine test shows dehydration. She is transferred to the acute medical unit and given an intravenous drip and her cardiac medication. The next morning, Saturday, Angela is seen by the on-call consultant for the weekend and given some medication. She is moved to the cardiology ward and not reviewed medically until Monday. She has been in a bed now for 3 days. 5 days after admission she is able to stand with assistance. Her physios aim to refer her to the local community hospital, but no beds are available. 10 days after her admission, whilst waiting for a community bed, she has a fall and sprains her wrist. She cannot use her Zimmer frame and she is bed-bound for even longer. 7 weeks after her first admission and 2 further falls, she is admitted for respite to a care home. Sadly, Angela never returns home. With better, more proactive virtual ward services, Angela could have returned home and continued to live a happy and independent life with her husband. Despite the best efforts of the health system and its dedicated professionals, a lack of patient centricity meant that it took someone who was independent and confident, and made them highly reliant on the system and unable to care for themselves. Rupert's story also demonstrates how the virtual ward service we have designed could both improve quality of life for people like him and save £32,000 on the cost of their care over the course of a year. Rupert is 28 with multiple long-term conditions. Although he lived with his parents, he has decided to move into his own flat to assert his independence. Since Rupert moved out, he has become more lonely and increasingly depressed. Rupert contacts his GP regularly but struggles to discuss the full extent of his needs in the short amount of time allotted to the consultation. In a crisis, if Rupert is unable to contact his GP, anxiety means that he generally contacts 999, leading to an ambulance call-out and an A&E attendance. On several occasions following an A&E attendance, Rupert has been admitted to a ward. Whilst it can be argued that is in his interest from a clinical standpoint, its impact on his mental health and self-sufficiency is negative. It reduces his confidence in his ability to manage future crises. During his stay, Rupert sees a large range of professionals and has to tell his story multiple times. There is also a significant wait to be seen by social services in advance of being discharged on several occasions. This results in longer than needed hospital stays. Following discharge, the lack of coordination between his GP surgery and social care mean that Rupert doesn't get all the care he needs in the short term. With his anxiety mounting and depression taking its toll, Rupert moves back in with his parents. Being looked after by his parents negatively impacts Rupert's self-esteem. He rarely leaves his room and is eventually admitted to residential care, when his parents are no longer able to care for him. With a responsive virtual ward service, Rupert's life could have been very different. Rupert would have been able to maintain his independence and live a long and happy life. Peopletoo are eager to work with systems and localities to develop locally configured, virtual ward models. we have developed approaches to: firstly, determine, on the basis of community resources currently available, the cost of implementing and running the service. Secondly, quantifying the likely cost saving of implementing the COVID recovery virtual ward service versus the cost of implementation. Thirdly, calculating the likely volume and value of the acute resources that will be freed up as a result of improved demand management. Please contact Dr. Folarin.majekodunmi at the email address to my right for more information.